Good morning. This is Chris Vandenhouten. I teach nursing at the University of Wisconsin-Green Bay, and this videotape is an interview with Dr. McGarvey, and I'll let him introduce himself.
Hi, I'm Mc Garvey from the University of Strathclyde in Glasgow. I'm over here on a visiting scholarship at the University of Green Bay, Wisconsin.
Thank you for joining us. And one of the questions I have for you is if you can describe a little bit about the political structure of Scotland in relationship to the United Kingdom.
Sure. Well, Scotland is part of the United Kingdom and has been part of the United Kingdom since Scotland signed an Act of Union with England in 1707. However, recently there has been more devolution of political power and authority to the Scottish Parliament, which was established in 1999. And some of you might be aware there was a referendum on whether Scotland should basically become outright independent from the rest of the United Kingdom in 2014. That referendum voted no by 55% to 45%, so Scotland still remains very much part of the United Kingdom, but there is still an ongoing sort of movement for more devolution of power and authority to Scotland from London and from the rest of the UK.
Thank you. Can you describe a little bit about the Scottish healthcare system?
Okay. Scotland's healthcare system is still very much part of the wider UK system. It's the National Health Service. Part of the philosophy of that system is that healthcare should be free at the point of delivery, so that individuals who are going to the doctor are not charged for the attention that the doctor gives them. In Scotland, they're not even charged for the prescription for the drugs, so the drugs come free. So when they take a prescription from the general practitioner to the pharmacist, that again would be free in Scotland. It's not free in England. They would probably charge the equivalent of around $12 or $13 for a prescription, no matter what scale that prescription is, you know. So, but the healthcare system in Scotland also has developed on a differentiated basis from the rest of the UK. There is a different philosophy where the commercial sector doesn't play quite a significant role in Scotland as it does in the rest of the UK. But in comparison to the US, the commercial sector is pretty low key in comparison to here.
Can you describe a little bit about how the system is funded or financed?
Sure. System is essentially funded by general taxation. Now, there are two types of taxation in the UK. There's the income tax. Well, there's income taxation. This is two paycheck taxations: income taxation and national insurance. Now, historically, national insurance was meant to be the part of taxation that funds healthcare, that funds social security. In reality, there's not a great deal of hype. There's no direct relationship between the national insurance and healthcare spending, so it's funded from general taxation. So the hospitals, the general practitioners, the subsidisation of drugs, everything is essentially funded by the public sector and by the government.
Can you describe what proportion of taxes then are directed toward health in relationship to other services?
Oh, off the top of my head, I wouldn't know a precise figure, but I think the comparative levels of healthcare spending, the UK tends to be at the sort of, in comparison to Europe, in comparison to the US and other developed nations, it tends to be at the sort of midpoint of expenditure on health, like the amount of money that goes into healthcare. In recent years, there was a big jump in the level of healthcare spending during the early 2000s when the Blair-led Labour government invested a lot more resources into healthcare. More recently, it's been protected from the government's austerity programme, whereby there's been a red line drawn at healthcare, and that healthcare funding has remained intact. And so inflation obviously has been running low in recent years, but healthcare spending has essentially gone up by the same as that rate of inflation.
One of the criticisms of the United States healthcare system is the heavy emphasis that insurance companies have on resources as well as on consumer utilization of services. Is there any type of an insurance industry in the United Kingdom or in Scotland specifically?
Yes, there is a private healthcare industry, and there are I would guess around 10% of the population could be covered by those healthcare, but they tend to be employer-led rather than individual-led. So it tends to be individuals in particular types of commercial employment at a senior level, may well, as part of their benefits package, as well as their salary and whatever else, may well have a private healthcare insurance system. So, and there are some private hospitals, but in relation and at a macro level, it's dominated by the public healthcare system. But there is an element of private healthcare as well.
Do you believe there's a different level of quality then between the private industry and the public system?
Touchwood, I have never really had to. I don't think I've ever spent. I've spent one night in my adult life in a hospital, but I mean things are likely to change. I'm getting older, but so I couldn't make a judgment. But I think the thing that people tend to comment upon is that a lot of the surgeons and the doctors who work in public healthcare also on the side can work in private practice. So it's the same individuals who are doing things, but obviously private hospitals will probably be a bit more luxurious, as in they'll be a bit like they'll look a bit more like hotels, and good hotels, than perhaps the public hospitals. Although, I mean, most of the public hospitals in the UK have been built very recently, so that everything seems very modern. But I think there will be a slight step up, I think, in the quality of healthcare.
In the United States, a lot of our health systems have moved toward more of those amenities, like looking like a luxurious hotel as opposed to what one would traditionally consider a hospital to look like. As a consumer of healthcare, are you pretty satisfied with the quality of the health services that are provided by the national system?
Sure, I'm very satisfied. I think it's part of the philosophy of the NHS is that the clinicians, the nurses, the doctors, the pharmacists are making judgments solely on the basis of a patient's clinical need. They're not getting involved in the politics of finance and what drugs they should or should not be prescribed, and these decisions tend to be taken at a more high political level. So, as I said, I've not got much personal experience, but obviously I've relatives. I've been in hospitals visiting, and yeah, I would say I'm satisfied. But obviously we're funding it through general taxation. I've got a few American colleagues who work in my school and the university, and they. Obviously, the general taxation at UK level would be higher than general taxation at American level, but obviously you've not got the insurance premiums of private medical insurance to pay from that take-home pay. That's
really an important consideration, and we look at the value of the service to the dollar. And you mentioned that it's free, essentially, and even the drugs are free to individuals in the national system. So whereas your taxation may be higher, an individual who needs to use health services, who has a very large deductible, would pay a substantial amount of money out of pocket. In fact, one of the statements that is made in a video series conducted by PBS, and it's called Sick Around the World, said that no one in the United Kingdom would go bankrupt due to a health concern or issue.
It simply wouldn't happen. Basically, it's always going to be funded but by the state. Don't get me wrong, there will be judgments made about, what drugs the state can support, because obviously there has to be some sort of cut-off point. If a drug costs £70,000 a year, should the state be supporting that? And that can, but I would assume what tends to happen is drug costs tend to come down, and it gets absorbed into the system, But the clinicians are making the sort of medical judgments rather than the more financial or economical or political judgments about healthcare.
So can you answer this question, and maybe you can't? One of my students works in a liver transplant unit. Are transplant services a part of the national health system? And if so, do people have to have a certain qualification in order to receive a transplant?
Okay. They are part of the National Health Service system, but the difference is because it's a state monopolised system, there will probably be waiting times for particular types of transplant, and there will also, if it's say a liver transplant and it's for someone who has basically had say an historic alcohol problem, there could be conditions placed upon that liver transplant, and that they have to show lifestyle changes, you know, if they want to qualify for that. So, but that would be the doctors and the clinicians would be making those conditions and those judgments.
That's really interesting,
Yeah.
and I know that's a big debate even in the United States, where there's a limited number of organs for transplant, and we have individuals whose lifestyle choices have put them in the position of needing a transplant. And so it sounds like your system is actually taking that into consideration.
Yeah, I think it's probably at the stage when the need is there. I mean, there's a lot more emphasis in the NHS now on preventative measures that let's have more healthy living, let's have more promotion of better diet, of, you know, that has been the general philosophy in the recent decades, has been to invest more resources into preventative measures that mean that because the costs of these things at a later stage in life can be very prohibitive.
You mentioned waiting times or waiting lists, and I know that's often a criticism of a social health care system. Yeah. Particularly the Canadian system gets a bit of a bad rap for that. Sure. Is that a common phenomenon in the Scottish system, or for that matter in the United Kingdom? For example, if someone needed a joint replaced and it's not an emergent kind of an issue, would they have to wait a period of time before they could have that procedure completed?
Sure. I think I'm not a specialist, so I wouldn't know the intricacies of each particular thing, but I would expect that there would be months of a wait for non-urgent needs such as that. It might even stretch to a year. You know, as in that, you know, there are probably, but all of these waiting times are published. Basically, the localised NHS boards are almost not. They're not in competition with one another for patients, but they're in perceived competition by comparison. You know, the question will be asked: why in the west of Scotland is the waiting time for that type of operation 9 months, when in this part of the country it's only 4 weeks? You know, so political pressures would be brought to bear if there's an underperforming health board, you know, or trust.
That's really interesting, and that brings up another question, which is what advantage, if at all, is there for one of the trusts to want more patients? So what would cause a system to want to improve their system such that they bring more patients in? Is there an incentive to having more? I don't think that. Well, the situation in England is slightly different from Scotland. In Scotland, it's the healthcare tends to be governed by what are called boards who cover a particular geographic area. In England, there are much more localised trusts, which might be one hospital or a network of local hospitals and healthcare facilities. So the only incentivisation would be financial, in the sense that if the more patients that you're covering, the more government funding you would tend to have allocated to you. Now, if you've got patients that are young, vibrant, with no great medical needs, you know, that those patients obviously tend to have a lot less demand for services than perhaps the more senior patients would have. So it can vary quite significantly. So with that in mind, if you happen to reside in an area that tends to be younger and healthier, is the compensation to the health system per patient, or is it based on the services that were provided to the patients?
It actually can be based on demographics, as in the percentage of particular types of population within a localised area. So or even deprivation levels that tend to be linked to, for example, pharmacies or doctors who happen to provide general practice in areas that are highly deprived tend to gain more resources from the state. So there's a lot. I mean, the grant funding formulas can be very complicated, very political, you know, because that's where these sort of formulas decide which areas of the country. And there is the phenomenon of what are called postcode lotteries, whereby it depends what you guys would call zip code that you reside in, what type of healthcare that you might have access to, because different parts of the country might make different judgments about what they will and will not fund. So, for example, if a new drug becomes available that targets a particular illness, the NHS facility down in London may decide we will fund that drug, whereas an NHS board in Scotland will say no, we don't think there's enough need for that. We're not going to fund that drug. So you can get differences across the country.
That's interesting. So do you think that it would ever cause an individual to move from one locale to another locale because, for example, maybe their child has an illness that's not as common, and they may get coverage for a drug that would help them in X zip code,
Yeah, sure.
but not in Y zip code?
Yeah, I don't think it would ever come to be moving geography, because they would probably be raising that type of thing with their local member of parliament, and they could try and politicise it and make it a political judgment, because the National Health Service is still very much viewed as either a Scottish-wide National Health Service or a UK-wide National Health Service. If the politician can raise it in Parliament, can put pressure on the NHS board to basically, or they can even use the judicial route, you know, as in they could challenge it in the courts if a judgment has been made over a particular thing. So those sort of avenues, those sort of political and judicial avenues are still open to the sort of consumer, if you like, or the citizen.
That's really interesting, because, you know, we'd like to think our health system is not a political issue, but here in the United States it certainly has become a very political issue. And it sounds like in the United Kingdom, because it is technically a service that is provided by the politicians, you can actually advocate for change through your political bodies.
Yeah, essentially, yeah. It's health is very much viewed as a public service, as it's just as education, just as other public services, you know, social care services that are provided in the public sector. So, you know, now it's not always solely public sector employees who are providing healthcare. Often it could be voluntary agencies, it could be sort of self-help agencies, it could be commercial practice that are providing it, but in the main it's publicly funded. You know, these voluntary agencies will be gaining access to public funds to provide the services they provide.
Can you give me an example of a public service or a voluntary service like you just mentioned?
Well, a lot of the church-based organisations run care homes, you know, so they will be funded by the local governments. You know, they will gain grants per patient to fund care for the elderly patients that they may have. So the Church of Scotland may well run a care home. I mean, they do run care homes, the Catholic Church or any other, or
sure.
even the wider voluntary sector, which the voluntary sector agencies can't. I mean, it's pretty big business, you know, that and can be running sort of packages, and often it's not only health, it's social care. It could be like care in the community, where they're sending individuals to know how to go on visits to have social care packages for people who are staying at home, basically to sort of to make sure that the hospitals are not full of people who don't necessarily have to be in hospital. So there's a lot of emphasis on care in the community, and like community nurses would be part of that as well.
That's really wonderful. Can you elaborate at all about what a nurse would do in the community? And by that I'm asking, you know, do they go into people's homes? It sounds like your care home is probably the equivalent of our assisted living or skilled nursing facility, which focuses on the care of individuals who have needs, functional assessment, functional needs, primarily older individuals, but not always. And so I'm just curious if you can elaborate a little bit.
Well, there would be what are called district nurses who would cover a particular area, and they would be. And for example, individuals who females who are pregnant, for example, would be visited by a district nurse at certain periods during the pregnancy, particularly in rural parts of Scotland. It would be a bit absurd to ask someone to travel 4 or 5 miles for a 15-minute appointment, with, you know, and so you can get. I mean, often you can get that, but you get it in urban Scotland as well. You know, when they are increasingly, in fact, it's just become a legal obligation on the part of local councils that they have to basically work in partnership with their local health authorities, and the social care services and the health services have become a lot more integrated, so that both the sort of social and healthcare needs of the individual, of communities, are dealt with together almost, you know. So that's been a recent change.
That sounds fabulous. So in other words, nurses are visiting pregnant women to ensure that their pregnancies are progressing well in a healthy manner. And if they see something that would cause them to be concerned, they can then refer them or send them to the clinic or wherever they need to be seen.
Or often it can be something like that they've gone to see their GP, and the GP obviously thinks they require a nurse to visit to assess whatever, you know, and to assess need and things like that. So it can be. Or even I was recently called into my local GP, to the nurse there, not just as a preventative measure to check my cholesterol levels and things like that, but and that might happen periodically. I suspect it'll be happening for someone my age more periodically or more often than was the case previously.
That's true. As we get older, we tend to need more services. And so can you describe a little bit about the population in Scotland? Would you say you have a pretty good balance of younger, older? Or are you seeing an increasing number of older individuals? Sure.
I think that like most advanced countries, the demographics of Scotland are changing, and that the sort of the population is becoming older. Although recently there's been a lot of inward migration because of the expansion, the European Union. There's been a lot of inward migration from Eastern Europe. There's a large Polish community in parts of Scotland now. The Romania, you know, because there's free movement of labour within Europe now, which basically means the 26 countries in the European Union, anyone can move and live and work anywhere in the European Union. And there's also been a lot of obviously the refugee sort of situation from Syria and from parts of like Somalia and parts of Africa. In the past 20 years, that there's been a more significant African community, and particularly the large cities in Scotland. So that's great. They tend to be younger, you know, they're having young families. So the population has actually started to grow for the first time in a number of decades. But it's still very small by US standards. The population of Scotland is only like 5.3 million people.
Okay. You brought up immigrants, and that is one of the biggest challenges, I would say, in the United States, is we have a lot of individuals who are here either documented or undocumented. And because your health system or service is funded by general taxation and the national insurance, what if someone is not working? Can they access services through your health systems? And how is that paid for?
Sure. There is no distinction made whatsoever if someone happens to be on working or not working, as in, so the doctor, the clinician, the nurse simply wouldn't ask these questions. So so even if you're not working, even if you're not contributing to national insurance or you're not contributing to general taxation, the same facilities are available to all. I think it's part of the philosophy when the NHS was founded back in the 40s. It was almost free healthcare became part of the rights of being a British citizen, as it were. So access to that, but even that's extended now to individuals who happen to be living in Britain should have the same, like under the EU rules, that a Polish person or a French person or a German happen to be living in Scotland or England or wherever in the UK would have access to the same services. And there are sort of reciprocal agreements. So if I happen to be holidaying in Southern Europe and Spain or Portugal, I would have access to their healthcare services in the same way.
That's interesting. So because of that, you don't necessarily see immigration to Scotland or immigration to the United Kingdom simply for the services of healthcare.
No, I think the studies that tend to show that immigrants, in the cost-benefit analysis of the situation, immigrants are actually working and contributing to the system. So very few are waking up one morning in Bucharest or in Warsaw and deciding, I think I'll go to Scotland for a free operation, because it's kind of those sort of lifestyle or major changes, but there's a lot more complicated than that. So that it doesn't tend to happen. I'm not saying that there are not individuals who might well be in Scotland on holiday and get access to services, but it doesn't tend to be viewed as a major issue. It's probably Scotland really doesn't have the same level of immigration as the southern part of England, like London in the southeast, because of it's so close to continental Europe. It's a much more vibrant economy usually than the rest of the UK. That tends to attract a lot more immigrants, and they put a lot more strain perhaps on public services. That would be the case in Scotland. Yeah.
In fact, in Mexico, there's such a phenomenon, it's called medical tourism, because it's so much less expensive to get services in Mexico than in the United States, that some U.S. citizens choose to go to Mexico for healthcare services, even dental services, because there is such a difference in the cost, even with insurance.
Sure.
And so it's really an interesting phenomenon. So it doesn't sound like that is an issue in Scotland.
It's not wholly a non-issue, but it's a degree
on
of
a
an
small
issue.
scale,
Yeah,
perhaps.
for example, like dental is one of the few medical services which is not free at the point of delivery, but it's still heavily subsidised, as in, to get a filling or get a crown, I would be expected to contribute not a lot of money, I have to say. It probably costs $30-40 for a filling, and maybe for a crown it might cost £400 or £500 pounds, which would be maybe $700-800, but that's not the full economic cost of that. That's still been subsidised. So to get that in private practice would cost a lot more money.
Oh, sure.
Sure.
That's really interesting.
Yeah.
Maybe we could shift gears a little bit and talk a little bit about the educational system in Scotland. We were talking a little bit about the fact that, for example, individuals who want to become a nurse or a physician, perhaps the physician could go directly to medical school. Can you describe a little bit about the educational system and how that works?
Sure. Essentially, unlike the US, if you want to become a doctor at the age of, say, 18, you could go straight to medical school. But you would be studying for quite a significant number of years, probably 6 or 7 years, before you would be doing placements and things in hospitals before you became a junior doctor. For nursing, students would be studying for 3-4 years to gain a nursing degree that essentially is a basic requirement if they want to become a Royal College of Nursing professional, and it may well take then 2 years of practice before they would qualify to be a nurse in the UK.
That's really interesting. So the equivalent, the Royal College Nursing registration, if you will, is perhaps the equivalent of our licensure, but a nurse may have to practice for a couple of years before they can become registered.
I think they can become something like associate members before, but perhaps before they gain the full professional qualification. It's a bit like if you want to be a lawyer, you can gain a law degree, you can get a practicing certificate, but you have to become a trainee lawyer for 2 years before you're recognised by the Law Society as a fully qualified lawyer. So
that's interesting.
Yeah.
And we talked a little bit about is it an associate nurse, perhaps somebody who hasn't trained in the university but is like an assistant to a nurse?
They would be called auxiliary nurses. So they would do a lot of the operational tasks that are associated with healthcare or care, whereas the qualified nurse would be more involved in designing the package of care that the individuals might require.
And that's really interesting. You were mentioning a little bit about some recent protests of junior doctors, and perhaps if you could just share a little bit about the structure of the medical profession. Okay. So you have junior doctors, senior doctors, and specialists?
Yeah,
perhaps?
You would have consultants who might be specialised in all parts of the body or particular parts of healthcare. You would have doctors, more general practitioner doctors, or accident and emergency doctors who obviously have to cover a whole range of different things, and then the junior doctors would be like newly qualified doctors, and often they're required to work long hours in the hospitals, It's been part of the culture of the medical profession for a number of years, and the problem, it's localised to England, but the Minister for Health in England has decided that to impose a new contract upon junior doctors, which basically doesn't differentiate weekend working from normal working, and the junior doctors have been going on strike for a number of months now, and the dispute is still unresolved. So it's still ongoing, but the contract has been imposed, but the situation is still very much ongoing.
It sounds interesting.
Yeah.
Is there anything else you think the students would appreciate knowing about your system?
Yeah, well, I think the basic difference in philosophy very much is that the commercial imperative doesn't really impact on it to the same degree, because the National Health Service is essentially a legalised monopoly. Mm-hmm. So when it comes to negotiating price with drugs companies and things, they want to be they want their drug into the system because it's the whole market that opens up to them. But it puts a lot of power in the hands of sort of central policymakers about who's making the big financial and economic decisions about the funding of healthcare, and what is and what is not getting funded. What the appropriate distribution of healthcare funding should be across the country. So it's essentially in philosophy, in sort of philosophy, it's sort of taking a lot of the decision makings away from sort of clinicians and healthcare professionals. But that's not to say that a lot of healthcare professionals might end up in sort of senior managerial positions within health boards, and will get involved politically and move away from the front line in making those sort of decisions. Yeah.
Certainly the pharmaceutical industry in the United States is probably one of the most profitable industries that we have. And so because the national health systems are actually negotiating those prices, I suspect the CEOs, perhaps, of drug companies aren't making quite as much money if they are based in Scotland versus in the United States. However, I'm not sure about that.
Yeah, I think like anything in the public sector or the government sector, the salary levels of public employees, that there is more political downward pressure on public employees than there may be on commercial employees. So the salary levels might not quite match what some of the commercial employees may be getting in the US.
Perhaps one last question, and that is, are health professionals then government employees?
Yes, yeah, essentially. Well, not all of them. I mean, I should say that a lot of, obviously, if you're running a sort of large monopolistic service, you have to have some sort of flexibility. So often there would be what are called commercial companies who will have registered nurses or auxiliary nurses in nursing banks, and they would be, local health boards would buy in those on temporary sort of flexible contract situations and things, or even individuals who happen to be employed in the voluntary sector. So, and even although their funding is coming from the public sector, general practice doctors are running essentially what are private practice. They could be they're gaining the funding from the government, but technically that they're not employed by the government. And similarly with pharmacists. So a pharmacist will be running a commercial business, and a lot of the funding for prescriptions is coming directly from the local health board, but they're still a private company.
Okay, so there's some private and public kind of levels.
Sure.
So it sounds to me like the Scottish system does have a philosophy of healthcare as a right. Yeah,
very much so, very much. And that's not only in Scotland but across the United Kingdom. That the notion of healthcare free at the point of delivery. So an individual can wake up in the morning feeling ill, and he or she has a right to go to the doctor and not be charged for it. So there's no. But increasingly, you can get charged for missed appointments, because obviously you're like, as in, well,
okay,
why, but that's, I mean, that's just but the charges would be quite small.
Do you think there's anyone who abuses the system? For example, there's a phenomenon called moral hazard, which means that sometimes you want to charge something for a service so that people don't overuse it. because healthcare is free in Scotland, do you think people might overuse the service?
I'm pretty sure. Yeah, I'm pretty sure that. I mean, undoubtedly that happens. You know, as undoubtedly, for example, in Scotland we have what are called free prescriptions. So you have individuals who can consistently go to the doctor, consistently get a prescription, go to the pharmacy, get that prescription, and they'll probably have drug cabinets filled to the brim at home. You know, for every eventuality.
Yes.
You know, but that. I have no idea to what extent that phenomenon would be. I'm sure it happens, but it's not. I think the judgment is, okay, it happens, but it's not enough to justify changing the whole system on the basis of these types of things. Yeah.
One, and again, I know I said last question, but I have one last question, and that is, you know, in the United States, we have a prescription drug abuse epidemic, and so you mentioned that people can go if they're ill. Do practitioners tend to avoid prescribing narcotics or drugs that could be abused, or is there a problem in Scotland with that?
I don't think I can answer that with any sense of authority, but I've heard of the issue. Let's just say that it could be a problem, but it's policed quite. I mean, the thing is, the local National Health Service body would become aware of that problem, and that there would then be a change of policy that would be sort of put down to doctors and pharmacists and things like that. So, but don't get me wrong, I'm sure that kind of thing can happen, and but doctors may well come under pressure. But don't get me wrong, there's lots of drugs that are prescribed on a routine basis by doctors. I'm sure that there are drugs that the legal drug taking, as in the things that have been judged that to be a need in 2016 compared to say 50 years ago, the whole environment has changed. You know, that there's we talk about an illegal drug culture. In a sense, there's a legal drug culture that people think they need particular drugs just to function on their everyday lives.
Sure.
So but I'm sure that happens in the US too.
Definitely.
Yeah.
Well, I want to thank you very much for your time today and your expertise. It's been really interesting getting to know the system a bit better.
Sure. Thank you.
You're welcome.
Thank you.